Well, welcome everyone to Palliative Care Friday Chalk Talks. Today, Marty has graciously allowed me to moderate this session. My name is Andrea Cordero. I'm one of the newest palliative care physicians over at St. Luke's Medical Center. And today we're going to be talking about neuro-oncology and palliative care, reviewing Dr. John Rhee's article, which is titled Palliative Care in Neuro-Oncology: An Update, which was published in Current Neurology and Neuroscience Reports on September 2023. As I mentioned, our guest is Dr. John Rhee. I'm going to give a little introduction. He's a board-certified neurologist, neuro-oncologist, and palliative care specialist at Dana-Farber Cancer Institute, an instructor of neurology at Harvard Medical School, where he takes care of patients with brain cancer and their palliative care needs, and runs a supportive care research program for brain tumor patients. He was formerly chief resident of neurology at Mass General Brigham and received his MD and PhD with distinctions in medical education, research, and global health from the Icahn School of Medicine and Mount Sinai. He is the executive director and co-founder of the Hippocratic Society, a community of physicians and trainees at chapters across the country, forming current and future clinicians in the practice and pursuit of good medicine. And impressively so, he's also a young member of the Pontifical Academy of Life, which is a bioethics advisory group for the Vatican.
Thank you so much for having me.
Yeah. Thank you, John. So, really, there is so much in this realm that it's worth talking about. And I got to read your article, and I thought it was an impressive review. Maybe the first question I'll leave you to kind of guide us a little bit. How does your team do it? How soon do you all have any algorithms? How do you decide which patients get referred to palliative care? How does it work with your team?
Yeah, it's a great question. And I think that this is still, in many ways, an unanswered question in this field, in the sense that, of course, the ASCO guidelines, when they talk about palliative care, talks about the importance of early referral to palliative care, right? And that palliative care can be given even at the point of diagnosis. Now, the problem, as all of you guys are very aware, is the fact that palliative care is also a limited resource. And so, in general, we think about palliative care in terms of how much can an oncologist do, and also how can we educate oncologists in terms of providing that primary palliative care, and then what time point is it necessary, or would it be important for a specialist in palliative care to then intervene, right, in terms of supporting our patients. And so, in different groups, especially with the Tamil group at Mass General, have been thinking about like when is the ideal time to intervene in palliative care for various types of cancer, consensus as to when the best time is. And I would even say that it depends perhaps based on what the type of tumor is, right? And so generally speaking, with high-grade gliomas, and maybe I would even say glioblastomas as the most aggressive form of high-grade glioma, the answer may be different than a patient with a lower grade glioma, right, where their prognosis may be in the even multiple decades, right? Whereas a glioblastoma, we know from studies that generally their average overall survival is in the range of like 1.5 years in the initial like STOOP study. That even depends on their methylation status. Sometimes it's less than that if they're unmethylated patients from an MGMT unmethylation standpoint. But then also that there are patients based on like how early the lesion was found, et cetera, that it's important to know that there are also some long-term survivors of glioblastoma, long-term being over 5 years in the glioblastoma field. And so how I at least think about it in terms of referrals for different types of neuro-oncological conditions is that for high-grade gliomas or glioblastoma, I think because of the fact that the diagnosis portends on average an overall survival of only about 1.5 years. We probably do a little bit better than that now with more interventions, but because of that, ideally, I think it would be a diagnosis. And the reason why I say that is because there's also a sense in which patients have cognitive deterioration over time. And so, in order to really understand their palliative care needs, but also to be able to have them participate as much as possible for as long as possible in their advanced care planning discussions, I think early as possible for high-grade glioma patients is ideal. At the moment of a cancer diagnosis, there's like a lot of stuff that's happening, like surgery, getting them ready for radiation, chemotherapy, etc. And so for glioblastoma, the normal trajectory is that there's like maximal resection, followed by chemoradiation for 3 or 6 weeks based on functional status, rest for 4 weeks, followed by adjuvant cycles of chemotherapy. And so generally speaking, I feel like probably a good time, and what I've been also trying to do with my patients is that that period of time of the chemo radiation, there's a little bit of a time in which I think that they're going daily for radiation, but perhaps midway through there could be a good time where a palliative care specialist can be seen both for symptoms, because that's when patients have more symptoms related to like nausea from the chemotherapy or just fatigue from the radiation, but also it's not in this like whirlwind of clinical trial questions and surgery and things like that right at the initial point of diagnosis, which can be very overwhelming for a patient. Of course, I think that as like both a neuro-oncologist, so I have like a neuro-oncology clinic, but also a palliative care clinic for neuro-oncology patients. I do incorporate in some serious illness conversation in that first pathology visit because I do think that understanding a patient's what's important to them also determines like what type of treatment plan makes sense for them, right? And so I do like a bit of a brief SIC there. But I do think that like a longer conversation perhaps can be had in the middle of that like 6 week chemoradiation. Now for low-grade gliomas, I think it's like less clear because even with the recent introduction of vorasidenib, an IDH inhibitor, since most of the low grades are IDH mutant gliomas, there is we are starting to see that maybe for first line treatment for the low grades. And also that I imagine because they live much longer, there may be different treatments that also become available. And so, kind of at what points does it make sense, especially if the prognosis for oligodendrogliomas may actually be like in the order of like 17, 20 years. Astrocytomas are a little bit more aggressive, so even though they're low grade, it's less than that. And so generally speaking, I feel like how we've been doing it is having patients referred for symptoms because low-grade glioma patients can end up having quite a bit of symptoms related to both fatigue, but I have found that they have also this kind of hypersensitivity or hyper-awareness of their symptoms as well that makes anxiety and depression much more prevalent in that population. And then the other thing that I've been noticing is that a lot of these patients after surgery may also have a lot of sleep issues. And I'm not really sure why that happens. It's just something that I've been seeing a lot. I wonder if there's some neural networks that get disrupted when you go and take part of the brain out from surgical standpoint. And then, of course, fatigue. Fatigue ends up being like a big issue, especially because these low-grade patients, they on the surface like don't seem to have cancer. Like it's like not very evident. And so because of that, they're trying to live their normal life, trying to like work, etc. But then they're still having these episodes of like intense fatigue. And so oftentimes I hear this perception where they know that they have this malignancy, and at the same time, because it doesn't seem apparent, they struggle a lot with the sense in which other people don't think that they have it. And so this kind of discrepancy between like how they feel and then how they're perceived as being something very challenging. And there's just like a brief point about the rest of neuro-oncological conditions, because there's also a lot of other rare tumors. I think we really don't know, and it kind of depends on like how the recurrence rates and survival work, especially in the adult population, one of the larger ones being central nervous system lymphoma. And I think this is like an area that personally I'm interested in and I'm studying right now.
Mhm. Yeah, I think you're very right. It's such a gray area in which, all of these tumors have different prognoses and, many times we end up seeing these patients in the hospital because they came because they had some weakness or they had some cognitive changes. They found it in the hospital and they started everything, as you mentioned, in the hospital, and they end up calling us. And, then they leave, they go home, rehab, wherever they go. So we try to keep continuity of care, obviously within the continuum of what they go through. But it definitely sounds like it's a difficult decision to make at which is the best time. So this is very useful and helpful. Um, I think your review does touch a lot of on symptoms in these patients, and you've mentioned a couple of them. What is your experience with cognitive rehabilitation?
Yeah. Cognitive symptoms are very high in this population, as high as in the literature, 90%, though I would say in my experience, like 100% of patients have some cognitive symptoms, right? But then we should be nuanced, because work from VCU, actually has been showing that despite it being very common, most patients, especially early on, meet criteria for being able to have both capacity, but able to have like fairly high level cognition for being able to participate in discussions, and many of them even are working early in their diagnosis. Patients often ask me, "Can I go back to work?" And I counsel them based on the fact that it depends on like how you feel. And I often tell them like during radiation, probably you shouldn't because that's like really intensive. But for some people, like having a sense of more normalcy is important, even in these like high grade patients. And that might be an important part of their identity of like who they are, and even coping with the illness. So with cognitive symptoms, I would say that we should be nuanced in terms of how we think about cognitive symptoms because patients actually, even though we worry about it, probably the large majority can still participate actively, especially early in the disease process. Um, and from a standpoint of like cognitive interventions, most of the interventions have been both like pharmacological and radiation based. So in the area of like whole brain radiation, doing hippocampal sparing, adding on memantine or donepezil to radiation, or trying testing out like stereotactic radiosurgery versus whole brain radiation when possible, doing it with more lesions. And so that's kind of where a lot of the cognitive sparing interventions have been. But there was an actually interesting neuro-oncology like editorial recently by Eli Diamond that I found interesting because of the fact that he was saying that though there are some pharmacological interventions with a lot of neuro-oncology symptoms, that perhaps we should be thinking more about the fact that there's also good evidence in the general cancer population for non-pharmacological interventions, things like exercise, things like cognitive rehabilitation. And so how we think about those things, even though they're not like as easy to prescribe, and therefore requires more counseling and guiding patients, that this might be a place where we have like bigger impact. And so specifically with cognitive rehabilitation, there have been like some small studies in terms of benefits. So there's been group therapy based skill-based learning. Specifically like a pilot study in the literature of a goal management training pilot. But also in our group, we've had experience with groups for our patients where we do particular neurocognitive skill-based training in different domains. So like whether it's like executive functioning or like memory, and patients can go through it for a few weeks to do this skill-based learning in a group setting with like a neuropsychologist. And so patients have been really enjoying that. And that skill-based part, I think, is important for them to be able to also both like recognize what their deficits may be and then be able to like find ways to work around those deficits. And sometimes it's like even as easy as, or I don't know, easy is the right word, but like something as helpful as for a patient. For example, yesterday I saw a patient who was telling me that she felt very distressed because of the fact that other people forget that she forgets, that if it's not written down for her, she's not going to oftentimes remember a conversation. And so she feels frustrated because other people like will say to her, like, we had this conversation. And she'll be like, yeah, but I don't remember it because it wasn't written down. And so we talked about just even ways in which she could carry one of those like pocket-sized notebooks where she gets into a habit of just like writing or jotting things down. But I think interventions like this actually can improve somebody's just daily lived experience, right, of how they're managing or going through the world, by focusing on the aspect of cognition that's helpful. And I think that that's where our speech and language pathology colleagues can be super helpful because they're so aware of this. And so I often send also patients to SLP for individual cognitive rehab because they do the skill-based aspect. And then I also use our neuropsychology resources so that sometimes for a patient where there's a sense in which I've even found there's a subjective sense in which their cognition is very impaired, but then on neuropsychological testing, they're actually scoring above average. Because I think that oftentimes people who are more aware are like very high functioning patients, right? But being able to provide that reassurance can also be helpful. And then I've also found that with that, sometimes you could see like what domain of cognition is being mostly affected. And so sometimes people might say like, oh, I can't remember things. And so you might think that the domain that they're having issues with is, I think, more of like an acetylcholinesterase inhibitor, like donepezil and memantine. But then if you actually test them, it might be more attention, right? Because we have to pay attention in order to consolidate memory, right? And so if it's attention based, then I find things that are more in the kind of ADHD category of medications can be helpful for patients to then help like support things like memory. Of course, cognition is so broad, so you have to think about, of course, mood things and other things that affect cognition and treat those underlying causes as well.
Yeah. Oh, of course. I think that as you mentioned, that's a very big symptom in this patient population, and some of the other ones, obviously fatigue. And have you had any significant experience with trying stimulants for fatigue, or is there usually a go-to medication or approach that you have for these type of for these symptoms?
Yeah, so I'm going to say this knowing that fatigue has a big placebo effect, and for that reason, a lot of the ASCO guidelines talk about the fact that neurostimulants are not like recommended necessarily for fatigue, but I have personally found it very helpful, and I will say like where I find it helpful, and maybe in like from my clinical experience, how it's been helpful. A lot of the studies that have studied fatigue, and so I'm personally like interested in testing this also as a potential intervention in my patients, and I found it very helpful. Is that I found that a lot of the studies, for example, when they do methylphenidate, they started at like 5, they increased it to 10, and then there's like one very old paper in Neuro-Oncology where they found that it's really only helpful when you get to 20. But when I hear like my patients talk about neurostimulant use, what I hear is that they find that it was helpful initially, and then over time it becomes less helpful. And so they're like, people are up titrating, it gets less helpful, and then at some point it's not very helpful. And so just thinking about that, I've been trying this in my clinical practice, neurostimulant use where I don't have them take it every day. Because I do feel like probably there is some aspect where taking it daily, maybe your body's like getting used to it, and therefore the stimulant is not as helpful when you're taking it daily. And so I try to help patients identify like when is it that you like maybe really need help here. And so for most patients, they're like, even yesterday, for example, I had a patient who told me like, oh, this was so helpful when I've only used it like 6 times in the past like 2 months. But the times that I used it were like when I was at my work desk and it was the afternoon and I was hitting that like afternoon really intense fatigue, which often happens with these brain tumor patients, right? And so she was like, in that moment, I took the methylphenidate and it woke me up and it helped me to get through the rest of my workday. And so I think that there's like this PRN use that may be more effective. I've also seen this in other patients where I've told them like, well, why don't you try to identify the day of the week that's a little bit of boost with your energy? And so I have another patient who, for example, like he's not working, he's retired, has a high-grade glioma, but then he really enjoys his relationships and talking with people. But the problem is that for dinners, he like can't make it through dinner because he's already fatigued even before dinner starts, but like he finds those relationships so meaningful. And so I think in this sense, what I told him was like, well, take it early enough so it doesn't disrupt your sleep. Typically, we don't recommend taking it after 2 p.m. or so because it can last like 4 to 6 hours and we don't want it to disrupt sleep. But if you take it early enough and you know you have like a big dinner engagement that night where you really want to be like attentive to your friends, why don't you try that? And he also only uses it a few times a month, but uses it in those circumstances. And he told me that it was so helpful in being able to just be more attentive, pay attention, be awake during dinners. And so I've been finding that like not daily use and using it in particular situations, some people benefit from 10/5, but that PRN use has been very helpful.
Oh, wow. Yeah, that's very, very interesting. And that's great information. I hate looking at the clock and seeing that I have so many questions still, but maybe, in reality, us as palliative care colleagues, maybe to close off, my biggest question would probably be, what would you say that the biggest takeoffs for us palliative care physicians would be, and how can we collaborate best with you all and with your team? How can we, be of more use and help as we move forward? Because as you say, the biggest thing is that palliative care has not caught up yet being embraced by neuro-oncology as fast as with the other oncology patients. So how can we move forward and improve these collaborations?
Yeah, I think that and I recently did some interviews with neuro-oncologists and palliative care physicians to try to better understand where this is. And there's also been good work by Rita Crooms from Mount Sinai, where she's done some initial qualitative work interviewing actually clinicians to see like where the issues have been in terms of referrals. But I often also hear from my palliative care colleagues that when they see a brain tumor patient on their lists, there's kind of like, oh no, because they're like not sure both from the cognitive standpoint how to interact with the patient, but also like from the symptom standpoint, there's not much evidence. And so I think on the palliative care side, there's also this little bit of dread that comes from when they see a brain tumor patient on their like outpatient list. And then on the neuro-oncology side, oftentimes the neuro-oncologists think like, well, I'm good at doing symptoms because a lot of them are neurologic symptoms. So why do I need to refer to palliative care? And so I think that there's growth in both sides, right? From the palliative care standpoint, I've been thinking about this a lot in terms of how perhaps we could offer this type of training through like professional societies where we could help palliative care physicians feel more comfortable with taking care of neurologic patients. And I'm not talking just about neuro-oncology, but also neuro-palliative care, I think is almost like a field where we have to approach things a little bit differently because the neuroprognostication can be so challenging, right? And how to approach patients in that context, but also helping palliative care physicians be more comfortable with the brain tumor population in terms of what things can be managed and what things can be offered. To me, the palliative care side that is like so helpful is definitely like the goals of care conversation and the advanced care planning, because I think from the neuro-oncology side, neuro-oncology still, I think, suffers from a lot of what oncologists have challenges with is that trying to maintain that balance between like hopes with the patient and therefore maybe not having a lot of those prognostication discussions. Or what I find is that a lot of my colleagues actually may do those prognostication conversations like early on, like right around diagnosis, because if you give a glioblastoma diagnosis, like to provide information, but a lot of what the patients ask me after that is like, what does end of life actually look like for me? Like, am I going to suffer a lot? Am I going to like, what does deterioration like look like? And there's a lot of fears around that. And so anticipatory guidance of that, I think, is actually very helpful and something that palliative care physicians can really help alleviate a lot of those worries and fears of patients by providing that. From an advanced care planning standpoint or discussions around serious illness conversations, I take like a little bit of a modified approach. I know you guys recently had Tyler Tate on as a shock talk person, and medicine into the SIC. And when somebody has cognitive deterioration, I think that that's the right approach, right? And so I always start off my conversation just being like, tell me the story of your life because I want to hear who you are. What are your values? And from there, learning about the patient, I actually just hearing their story can help guide them in the advanced care planning discussions because I get to know like their identity, their source of worth, like how they're thinking about all of these things. And then only after that enter into the prognostic awareness discussions. I think the other framework from like Vital Talk, SIC, that's very helpful, is from maybe the surgical literature. I use this a lot, which is the best case, worst case, most likely. Because of the problem with neuroprognostication sometimes being more difficult, I find that if you use that framework of like, this is the best case and we hope for this, this is maybe the worst case and we don't hope for this, but this is like most likely what will happen. And so, there's this range, but let me try to help you with anticipatory guidance of like what is most likely to happen in these different scenarios. And I find that that is a framework that also patients are very find very helpful. And so maybe those are some of the things from, at least from a palliative care standpoint, with this population that might be especially helpful in terms of approaching these types of conversations. Oh, and then sorry, just one more thought that I want to share. Of course, like patients can sometimes have challenges in terms of like wanting to talk about prognosis, but then patients resist. The other thing that I found patients respond well to is, I only want to have this conversation with you because I want you to live your life in a way that's meaningful to you. And if time were short, you may decide to live your life differently, right? And so, are there trigger points if a person's very resistant to talking about prognostication or prognosis? Are there trigger points that would make this important because then maybe you might make decisions differently? And I find that patients also respond well to that because then you could use those trigger points of like, bevacizumab, for example, is like our last line of therapy for high-grade gliomas and usually portends like a 6-month prognosis. And so to me, like that's almost the latest time we should be having this discussion because we know that the overall survival is only 6 months from there. And so I think that these kind of trigger points in our mind can be important times to really then push a patient, be like, remember we had this conversation, and I think it's important now because you may choose things differently in terms of how you live your life now.
Yeah. No, I thank you. I think this is very helpful information for all of us, to be honest. So I appreciate that. I think Marty has a question that he.
I got one last quick question. And you already referenced it, so it's perfect. I was going to ask you about that anticipatory guidance because just like you, one of the most common questions I hear from either the patient themselves or the family, especially when we're here in the hospital and things are starting to get pretty serious, is what are those last days to weeks going to look like when I've got a high-grade glioma and it is progressing? And I understand maybe nobody follows the textbook exactly, and you can't say precisely, but what is the typical textbook sort of progression for those final days to weeks?
Mhm. Yeah, and because there's not that much literature out there, I could tell you my personal experience, like clinical experience, which is that, which I find that actually patients find more comforting because I think that there's a lot of fear about what could happen. And in the last days, 2 weeks, I find that it's more about people getting like sleepier and sleepier. So like just spending more time of the day sleeping and less time of the day awake. And so there might only be like a few hours in those last few weeks where people are awake and spending most of their time sleeping. And so, but it's kind of a progression where people end up slowly kind of sleeping more and then not waking up anymore. And so, in that way, I think it's that kind of progression is like less scary than thinking about being in like an intractable pain or like, and of course, there's slight differences here because of the fact that if like behavioral issues are like a predominant kind of presenting cause and there are like a minority of patients where like behavioral cognitive issues become like a real issue because they're still physically strong, but then have a lot of those behavioral issues. But that's like a very small minority of patients. Part of it, I think, is also to go into like our neurology clerkship memories and pull out the fact that a lot of the progression happens like in the brain where the lesion is, and so a lot of the initial presenting symptoms oftentimes are what progress over time. And so that's kind of the anticipatory guidance of what happens with like ongoing progression. And so you don't even have to like localize very well. You just know that if these were like the initial presenting symptoms, those are typically the things that progress. But at some point, also, I find that for patients, because of the fact that with the fatigue and also just more sleepiness, there's a little bit of like blunting of the affect over time, especially in the frontal lobe tumors. And so I find that actually from the patient standpoint, there's less distress in those last like days to weeks. And oftentimes where there's more distress is with the care partners. And I think that that's also important for us to know as palliative care physicians because they may be a shifting also of like being aware of where the major distress may lie. Because as there's kind of blunting of emotion or kind of reactivity from the just the effects of these tumors, the care partners might be the ones who are like especially distressed. Yeah.
Thank you. very much. We appreciate that. I think that this is a branch and this is as you say, a specialty that it's within its specialty. And these patients are very complex. So we appreciate you taking the time to discuss this with us and hope you have a great rest of your day.
Thank you. Thank you so much for having me.
Thanks, John. Take care.